समरो मंत्र भलो नवकार छे 14 पुरवनो सार समरो मंत्र भलो नवकार छे 14 पुरवनो सार एना महिमानो नहीं पार एनो अर्थ अनंत अपार एना महिमानो नहीं पार एनो अर्थ अनंत अपार समरो मंत्र भलो नवकार छे 14 पुरवनो सार समरो मंत्र भलो नवकार छे 14 पुरवनो सार सुख में समरो दुख में समरो समरो दिवस निरात जीवता समरो मरता समरो समरो सौ संगात समरो मंत्र भलो नवकार छे 14 पुरवनो सार समरो मंत्र भलो नवकार छे 14 पुरवनो
Sone Pranam, Jai Jinendra, and good evening. Thank you, everyone, for joining us for part 2 of this very important subject, end-of-life care. Aje આપણા સાથે છે ડોક્ટર અજીતભાઈ, જે પાર્ટ 1 માં પણ આપણે જો સાથે જોડાયા હતા. And also a pleasure to welcome Nikunj Bhai, Dr. Nikunj Shah from South London, and Nikita Ben, who is also here. So, આજે આપણે આ end of life care part 2 cover કરીએ છીએ અને અજીતભાઈ અને નિકુંજભાઈ આપણે થોડીક માહિતી આપશે. A lot of the information we are going to hear today is very, very important for us as a community, but also more importantly for families to discuss together. There are a lot of challenges, particularly for our elders, when faced with this particular topic. And we're trying to just learn together and see if we can navigate this difficult journey as a community. A little bit information about our speakers today. So Ajitbhai needs no introduction, but I do feel we should honor some of the wonderful work that Ajitbhai does for the community, not just on the health side, but some of the work that he does in teaching Jainism to the community. So Ajitbhai, thank you for that. I know it's almost like 2 jobs in one, in fact 3 jobs in one. You do a lot of the teaching online and classes face-to-face as well. On the health side, Ajitbhai continues to be a GP, as a GP practitioner, working with families and particularly in the community. A lot of the elders he has become a trusted friend to, but he's also a very important part of Brent Health Matters, who we work with locally at Northwest area as well. Nikunj Bhai is very involved with Oshwal Association South area, but in his spare time, Nikunj Bhai actually does a wonderful job at a hospital. And the hospital that he is currently working for is the Ashford and St. Peter's NHS Foundation Trust. Nikunj Bhai actually did his training at St. George's Hospital in South London way back in 2003, went to do training in Salisbury, and then came back to London in 2014. He is involved in a lot of very high-level decision-making when we talk about critical care and anesthetics particularly. He is part of a team that is also working as an outreach team in the community. So Nikunj Bhai, thank you for giving up your evening today. I know you finished a shift and you've joined us straight afterwards. So very, very grateful for you to do this today, and hopefully we will share some really good and useful information for everyone. Today's agenda includes a little bit of a recap on part 1, which Ajitbhai will do. We will then hear from Nikunj Bhai, and then going back to Ajitbhai, and myself and my colleague Nikita Ben, who's here from Northwest Areas Committee, whose portfolio this actually is. So Nikita Ben is the Health and Wellbeing Portfolio Lead. So she and I will handle, hopefully, and facilitate the Q&A at the end. If you do have questions, so તમારા પ્રશ્નો હોય ને એ તમે અહીંયા Zoom માં chat માં મૂકી શકો છો. Yeah, at the end, you will have an opportunity also to put your hand up and ask the questions. I do request, though, that everyone please remains on mute while we do the presentations. And if you do have any questions, as I said, you can either directly put them in Zoom here or put your hand up at the end. Right, so without further ado, I'm going to go to our first guest, Dr. Ajitbhai Shah. Ajitbhai, we're going to do a recap first, and then we're going to go back to Nikunj Bhai. So lovely to have so many of you join us as well this evening, and we're going to keep admitting people as you join us. Thank you all very much.
Pranam, Jai Jinendra. It's a pleasure to be back and come back and talk further about this very important topic that, as I explained last time, I've been trying for years to go to the communities to try and speak about death and how to prepare for death. આજનું આપણું જે વાત કરવાની છે એ ગુજરાતી અને અંગ્રેજી બંનેમાં હું વાત કરીશ. એટલે કદાચ જો કોઈને તકલીફ પડે તો સવાલ કરજો અને આપણે એનો કંઈ જવાબ આપવાની કોશિશ કરશું. ગઈ વખતે અબાઉટ લગભગ 3 મહિના પહેલા આપણે મૃત્યુની તૈયારી, બીમારી અને મૃત્યુ એના બારામાં આપણે વાત કરી હતી. We talked a lot about some of the basic difficulties that we have when faced with a scenario where it seems as if our life is going to end, or we see a relative who is getting iller and iller, and one sad day somebody communicates this to us and says that it is likely that your mother, father, relative may not be with us for very long. And we discussed how medically we define the period which we call end of life. So let me share my slides with you and I'll just quickly recap what we discussed. There are a few slides. You may have some questions on this. I've shortened the presentation from last week and we'll discuss more of it in the second part. In practice, the title of this slide is something that we all know, but it is also very hard truth to accept and digest. Even though we know it's inevitable, sometimes it is very, very difficult to accept that life is going to come to an end. And this is probably the most important part of our work as doctors that we struggle with, and every patient struggles with. And constantly, as we know and we've seen in the last presentation, that hope is something that we would all find very difficult to give up. Patients who are approaching the end of their life need high quality treatment and care that support them to live as well as possible until they die and to die with dignity. And I think the important thing that we were trying to convey last time was that dying with dignity is the key phrase here. And it's important to understand that. And sometimes the balance between aggressive interventions and dignity is difficult to achieve. Patients who are approaching the end of life, when they're likely to die within the next 12 months. This includes patients whose death is imminent within a few hours or days. We talked about situations where we would discuss with patients that the end of life is approaching, when there is advanced, progressive, incurable conditions, general frailty, and coexisting conditions there, and that which will likely end up with death in a few months. Some conditions which are acute and may deteriorate very fast, and life-threatening acute conditions caused by sudden catastrophic events. And I think a lot of this will be Dr. Nikunj Shah will talk to us about those kinds of situations in his experience. Questions and care decisions. This is a new slide, but just to put into context what we are going to be talking about further. Questions that come to our mind when the doctor presents to us the idea that death may not be too far. It is accepting that because there is a constant fear of death. The question that we need to ask ourselves is, how do I feel now, having been given this bad news or this news? For some people, that may not necessarily be bad news, because people may feel that I've been waiting for this. And a lot of my patients in care homes often ask me, when is this going to end? What can I do and what can I not do? How long have I got? What treatment will I receive? What will be the aim of the treatment? Will the treatment help me live longer or live better during my remaining days? What is important for me? All these questions are questions that every patient faced with this end of life situation will ask themselves if they have the capacity. And this is often the key issue, that a lot of patients, having reached that stage, have lost the capacity to think this through, because this question has never been addressed while they were alive. And this is some of the things that we are trying to do in the community, to make people aware and start talking about this end of life situation long before that day comes. Other questions: should I receive cardiopulmonary resuscitation? What will hospitalization do? What is the ceiling of care? And when family members are faced with this decision on behalf of the relative, then the family members have to put themselves in the loved one's shoes and answer these questions for them, if the patient is unable to do. Logically, we are near to death the older we are, and we talked about frailty last time at this point, and we actually covered this in quite a lot of detail. Just one slide about this Rockwood frailty scale that I shared with you, and it's available on the internet if you want to look at it in greater detail. But the relevance of this was with respect to the decisions that we take for the very frail and elderly patients that are under our care. For the patient, it helps if you know what you want. And one only knows what one wants when one has thought about it long before the day comes. And for the relatives, it helps to have discussed what your loved one would want. And again, my whole emphasis has been to bring this conversation out in the community, so we talk about death without fear, well in advance. Patients who are severely frail, very severely frail or terminally ill would benefit from conversations about death, which could include discussions on resuscitation and ceilings of care. But it would actually be wise for us not to wait until we reach any of these categories and to discuss it when we are well. And that's some of the things that we will talk about. So I'll end this introduction. It just outlines what we discussed last time in April. And I'll hand you over to Dr. Nikunj Shah.
Thank you. Pranam and Jai Jinendra Badhaina. Unfortunately, my Gujarati is not as eloquent as Dr. Ajitbhai's, so my presentation will be given in English, but I'm very happy to take questions, and I will try my very best to answer them in Gujarati. Let me just share my slides, because everything that Dr. Ajitbhai has just said resonates very well in the hospital setting. And my presentation is related to what it means to be in intensive care, and talking a little bit about the concept of do not attempt resuscitation, Some people in different hospital environments may have come across the respect process, which is another way of framing the conversation around what one wants in an emergency situation, and essentially being able to express that with a detailed conversation with a healthcare provider. And that gives us a very clear and quick idea of what people would want in different circumstances and scenarios. So as Prof. Ben kindly introduced me, I'm Nikunj Shah. I'm a consultant in intensive care medicine and anesthetics. I have the fortunate sort of grace to work at Ashford and St. Peter's Hospital, which is down in Surrey. For anyone who wants to come this far, it's down at the end of in sort of junction 11 off the M25. This is the intensive care unit I actually work in. And right at the bottom in the middle of the screen, you can see me and a few of the staff I work with two patients, the gentleman in the black t-shirt and jeans, and the lady next to him in the very colorful outfit, whose permission I have to share this photo, but both of them are survivors of cardiac arrests that happened in the community. And they ended up at St. Peter's Hospital, and they ended up going through a process of intensive care, which was very distressing for them and for their relatives. But thankfully, they are lucky to have survived and are here to tell the tale. And they made a very generous donation back to the intensive care. So many of you will be aware of what intensive care is, but just to summarize, intensive care is a specialized ward in a hospital. Why is it specialized? Well, it has a higher nurse to patient ratio. So we have patients being looked after one-to-one when they're on ventilators, when they're very, very sick. But as they're getting better through their journey, their reduced ratio goes to 1-to-2. And then by the time they are ready to discharge from intensive care to the ward, they will experience a nurse to patient ratio of one nurse to probably 6 patients, sometimes 8 patients. So you can see automatically the intensity of the work that is required to keep people alive and to treat them. What things do we do? Well, we give respiratory support, so we put people on ventilators, and I'm sure the entire world now is very aware of what happens on intensive care after having experienced the pandemic. So you've seen people on ventilators, you've seen people on CPAP machines, and this is something that I do routinely for patients that require it. We give them very, very powerful support for their hearts. We provide lots of support for kidneys in the form of dialysis type treatments. We look at patients in a very holistic way in intensive care. So many people who go to a hospital experience very specialist care. So if you have a heart problem, you'll go to a cardiologist, you'll go to a cardiology ward, and you'll be treated by that cardiologist. But on intensive care, I have to be able to support the whole patient. So that includes their gut, making sure they're being fed, making sure that their bowels are working. We look after patients who have had very, very significant operations that need intensive care, recovery and monitoring. And we deal with lots of other issues such as pain and different types of pain treatments we provide people that can't be managed with normal medications on a ward. And then we're involved with the organ donation and end of life management, and hence why I've been asked to come and help present this part of this talk. So which patients go to intensive care? Well, very similar to what I've just described, but patients who end up coming to intensive care usually have some form of infection that needs their organs to be supported while they are trying to heal from the effects of the infection when we are administering antibiotics, supporting the patient's immune system. We're providing specific drug treatments for these conditions and a high level of monitoring, because when people are in the intensive care, one of the things I say to relatives and patients is, you must remember, when you're in intensive care, you're in the category of around the 5 to 10% of the sickest people in the entire hospital. Okay, so it's a very, very acute area where things go wrong very quickly if things aren't recognized, and hence why we need so much monitoring. We also look after people who've got kidney failure, lung failure, heart failure. We look after emergencies related to diabetes and high blood pressure. And then I've put on this slide stroke patients, and I put less likely. And there's a reason for stroke patients being less likely to come to intensive care. And the reason for that is that if you've suffered a stroke, you will have obvious treatments, and there are very good, clear treatment pathways for stroke patients. But if you have suffered a stroke that is severe enough for you to need intensive care, then there is a very high chance that you may not survive intensive care as a result of the stroke itself. And so we need to look at each individual case and decide whether or not this patient in front of us, with the degree of the stroke they've experienced, is someone that will likely benefit from intensive care, or do we make the decision that we need to have standard treatments, or do we need to make the decision that we are in a process of looking at end-of-life treatments? We sometimes admit patients who need unusual drugs, and the reason being is many of our NHS wards now are not used to giving unusual drugs, or drugs that are very, very sort of toxic to the body, and therefore will need an intense amount of monitoring. And I think the last part of this slide categorizes everything very well, which is, we need patients in intensive care to have something I can reverse. Because if I've got something I cannot reverse, and the trajectory of that patient's pathway looks like it is of deterioration, then we as doctors, nurses, and families have to understand we are approaching a situation where there is no further treatment, or we need to enter end-of-life pathways. So this is something that's very, very important. And it's interesting when we talk about patients in intensive care and families. So this slide represents some research that was done where we looked at how do patients themselves feel after having been in intensive care. And we have thousands and thousands of patients in terms of data. And many of them say they feel safe. Many of them feel very scared, very frightened, very confused. Many of them, because of the effects of the drugs or the disease that they're experiencing, don't have a memory of the time they were actually in intensive care. A lot of patients describe very traumatic experiences. Now, we would assume we're trying to do the best for these people. We're trying to give them the most amount of help and support. But they are surrounded by people who they don't recognize. They're surrounded by interventions and procedures that can cause pain or discomfort when we try to put them on these medications and trying to support their organs. And they recall this later on after surviving intensive care as having very bad traumatic experiences. Some people remember vivid hallucinations and paranoid thoughts. Very commonly, people think that while they're getting better in intensive care, and we can see they're getting better, in their mind, they feel that people are there to harm them in some sort of way. And that's a very common situation in intensive care, especially when you're sick. And then the recovery time. A lot of patients have said very clearly that if they had to look back on their own journey, before they got unwell, before they were admitted to hospital, and then after their recovery, and looking back over that time, many patients report that it takes them up to 2 years to get back to the normal function of their normal daily lives before they were actually admitted to hospital in the first place. So you can imagine that's a huge portion of time where you've had to recover and get back to some sort of normality. Many of these patients still have lasting effects afterwards. And it's very scary for those who are being loved and being visited by family and friends, because the relatives and the friends describe that they think ITU is a very safe place. They recognize there's more doctors, more nurses than most of the other wards. There's always more information that is provided when people are on intensive care, because people are sick, we need to be making people aware how sick people are all the time. And so we provide a lot of updates to family and relatives in this situation. But that's not the same on a standard NHS ward. And they sometimes feel very frustrated, because if you were unwell and you were surrounded by your loved ones, they would want to help you. They would want to do things for you to make you better. And they feel very frustrated that they can't help in normal daily care because it's being provided by strangers in their eyes, or friends in nurses and doctors. Sometimes people feel very scared because they think that they have to make decisions, and they are suddenly put, while they're in an emotional situation, dealing with the grief of someone being admitted and being unwell in the hospital, they're dealing with very, very difficult decisions that they may have to make. And this can lead to a feeling of being overwhelmed and not being able to function and make decisions appropriately. And it goes back to what Ajitbhai was saying, was it's better to know and have these discussions, if you can, earlier, so we know what our loved ones would want in different situations. And I'll come back to that in a moment. So ITU is a very, very safe place. It is a very, very interesting place, and it's, our role is to get people better and to aim for survival. And the average rates quoted these days in intensive care, the average rate of survival, and this is generic, this is global. When you get admitted to intensive care, 65 to 75% of patients survive. Now, survive does not mean function. Survive means we have got them to a position where we have managed to get them out of intensive care. Then the road to recovery gets harder and it's bigger, and essentially we then need to get people functioning. And the things that allow you to get better or survive, through intensive care and better through your journey of illness, things that are common sense in some ways, your age. I mean, the older we get, the closer we are to dying, as we've already mentioned. The number of medical problems you already have, and determining whether those medical problems are sufficient and chronic that they lead you to develop a level of frailty. Because if you're frail with lots of medical problems before you even get admitted to hospital, that has a huge impact on your ability to survive intensive care. It has a huge impact on your ability to recover overall and even get to a level of function that you were at before you come to hospital. And then other things like surgical or medical problems. If it's a surgical problem that can have a direct fix that is easily fixable, it would stand to reason that you would have a better outcome and your chance of surviving is much better, as long as you don't suffer complications. Medical admissions usually are on a background of chronic ill health, unless there are specific acute issues that have arisen without any problems previously. And what do we want? Well, the outcomes that occur from intensive care, there are only really 4 things that really happen to people overall. We get patients out of intensive care, out onto the ward, they go home, they eventually get back to a normal function. Or they go home and they have a level of frailty which needs either some assistance to manage at home with things that we all probably take for granted, cooking, cleaning, going to the toilet, getting dressed, washing ourselves. So patients get to the position where sometimes they can't do those things for themselves. Some patients get to the position where actually they cannot manage, and they may need the assistance of nursing or residential care homes where there is a slightly higher level of support available. And unfortunately, a number of patients do end up on that dying pathway. And that's when we have to recognize that this is a pathway that we need to be open and honest about, and we need to understand. And sometimes it's difficult when your loved one have been admitted into hospital, because decisions are being made behind the scenes. And what I get asked quite often once patients are either in intensive care, or I have made a decision that this patient will not benefit from intensive care treatments. And the question is well, who decides if someone can go to intensive care, and how is that decision made? Well, the decision is usually made by an intensive care consultant, or a team that they work with. They will usually have a minimum years of 7 years of post-registration training to become a consultant. The decision is never based on age alone. Okay, we are not ageist. We look at a number of factors. So we look at how frail the patient is. How many medical problems does this patient have? Are these medical problems chronic and something that we can reverse somewhat or control? Or are they essentially conditions that are actually not reversible, there is no cure, and we are just dealing with a situation where we've got to manage the complications of a condition? We then need to understand what the current reason for admission to intensive care is, and whether that patient would survive those kind of interventions, because there is a huge stress on people's bodies when we put them through intensive care. And I can refer back to what happened in COVID, and the picture describes that very clearly. People who are young, fit, ending up on ventilators, yet still dying as a result of being on those ventilators and being in organ failure secondary to severe COVID infection. We also want to know what the patient's wishes are, because this is actually very, very important. And it's the patient's wishes. And sometimes when we are so emotionally involved with our loved ones, it's very difficult to separate what you want from what the patient wants. And sometimes the patients will look to their relatives and their loved ones and say, you decide, you tell me what you think. And that's fantastic, because it starts to open a conversation. But what I must say, and what I have to be very clear about in terms of the medical legal standing in this country, is that these decisions are not directly family decisions. These are decisions made by the patient, the physicians that are treating that patient, and the opinions of the family are considered during those discussions, and the discussions around what is appropriate treatment and what is not. And one of the things that I would encourage all of you to look at some point is to look at the government website for the lasting power of attorney for health and welfare, because you as an individual can nominate people who can stand in for you, who can be involved in these discussions, and at the time when you cannot make these decisions yourself due to the ill health that you may be suffering, because you've lost the capacity to make those decisions. And that's very important, because it provides a legal framework for us to work with, because you can nominate people and we can be having those discussions directly with those people when you're very, very sick. And it's something I would encourage all of you to do at some point. Frailty is interesting, and this is very easily accessible on the internet, but essentially you can look this up. This is called the Rockwood Frailty Score. It's a scoring system that many NHS trusts use when they're looking at how well you are. And if you imagine that when you come to intensive care, if I tell you that if you spend 3 days or more in intensive care, you will drop 2 points minimum on this scale. So if you were incredibly fit and running marathons and had a score of 1 at the top, and you came to intensive care and you had to spend more than 3 days in intensive care, then the likelihood is that you're going to leave hospital at best with a score of 3, where your medical problems are controlled, they're not regularly active, but they may be encroaching on how you behave and how you function. So walking upstairs, bathing yourself, etc. The other thing is that obviously as you score higher and higher, and you can recognize on this scale, family members, friends already, and I'm sure many of you are already trying to put yourselves in which category you fit or your loved ones may fit in. But remembering that the scores get worse and the ability to function gets worse, and then you develop an ability of developing chronic health problems, which can impact the way you are outside. But for every time you then come to hospital, that takes another hit on your body and could put you at a lower score further still. And when we talk about function and trajectory, if you're going to take anything away from my talk, I would like you to take away this slide. So while this is busy, this will open multiple discussions with many people. At the top, there is trajectory number 1, the path of the blue line. This is a patient who has usually has had some sort of nasty diagnosis of cancer or an organ failure problem, and they've been functioning quite well in the community with high function. High function meaning you can carry on all of your normal activities of your daily life without any assistance. And you've been managing and managing up to a certain point, and you will come to a point where suddenly your health may deteriorate, and the trajectory you take is a very sudden, acute problem where you almost enter end of life treatments very, very fast. And this is the case where people suddenly have diagnosis of cancer that has spread to multiple organs, and we can tell that with treatment we can maybe control it a little bit, but the likelihood is that how aggressive the cancer is, how fast it's spread, and how quickly it's come on, and how late it may have been possibly diagnosed, has led to you deteriorating very fast. And therefore we need to make plans for the end of life situation. The majority of people don't fall into that category. The majority of people fall into the trajectory number 2. And the trajectory number 2 is where you have a chronic health problem. Now, I don't want to scare everyone, and I don't really want any complaints coming through, but we need to be mindful that this is where you've got a chronic health problem, and every time you have a sudden deterioration, the chronic health problem gets worse, and your overall level of functioning continues to deteriorate. And it's very important to have those discussions, because that trajectory at some point will end up in a progressive problem that will end up with treatments that we can only support symptoms, and symptoms which will then end up in end-of-life treatments. The last sort of set of graphs is essentially someone who is the trajectory has been declining very, very slowly over a long period of time, and the example there is people with dementia or overall frailty that's developed over a long period of time. So I've got a few slides. I know I'm trying to speed up now because we're slightly short of time here, but one of the things that we sometimes see is cardiac arrests, and you will have access to these slides if you wish. It's certainly on the recording, but there is a number of different risks for cardiac arrest. And cardiac arrest is when your heart stops, but that stops for multiple reasons. And those reasons are in all of those pictures there. One of the things I will say on this slide is, many of us in the community have heard this heard the story of someone having an attack of some sort, a heart attack or a brain attack, and that's not particularly helpful because we don't know the underlying direct cause of what happened. Obviously, when someone has a cardiac arrest, we provide cardiopulmonary resuscitation, and we essentially press down on their chest to try and restart their heart. We provide them with oxygen, and we're trying to ensure that there is blood flow to the brain and to the heart to try and restart the heart and protect the brain from damage. The effects are obviously can be very devastating because you can have a severe brain injury from resuscitation or cardiac arrest. You can most likely will need life support of some description, so on a ventilator, heart support, kidney support. You may have severe fractures to the ribs in the chest, and that can have major impact on your rehabilitation. So one of the things that people are very scared about is this concept of do not attempt resuscitation. And it's very poorly understood by many patients, many staff. What it does not mean is when you have one of these six do not attempt resuscitation forms, it does not mean you are not having treatment. It means if you were to suffer a cardiac arrest, we will not resuscitate you. But up until that point, you should be given all active treatment that is appropriate for your medical need. And the decision before that may be that that's not appropriate and we need to end the pathway at an end of life scenario where the treatments are switched from trying to help you to cure you to support your symptoms. It doesn't mean you can't come to intensive care, because I can still take you to intensive care and give you all of the treatments, but if the pressure on your heart is so great from the disease that your heart stops, then you are not likely to survive. Okay, but I can still take you to intensive care, potentially. The other thing is it's not a legally binding form, and the decision can be changed. Okay, so the decision can be changed at any point, depending on what needs to happen. The decision to resuscitate or not to resuscitate ultimately is a medical decision. It is not a patient's wish or decision. Patients can wish it, patients can express they want it, but the ultimate decision to provide the treatment is a medical one. There is no such thing as someone can demand that I must be resuscitated or I must, not be resuscitated. If you show clear signs of understanding of what it means not to be resuscitated, or what it means to demand resuscitation, then you need to enter a conversation with a healthcare provider and work out what would be best for you in your own personal circumstance. In some hospitals, or in community settings, we use something called the RESPECT form, which is a bit more of a detailed form, but it's a recommendation of a plan in emergency care and treatment. And it summarizes your health issues, it summarizes any discussions you may have had with the healthcare provider. It asks you questions about what you think your priorities are in terms of treatments or comfort. It allows us to adjust and amend this as time goes on and as you interact with different healthcare providers, because ideally you as a patient would keep a copy of this and take it to all of your clinics and interactions. And then, as Ajitbhai alluded to earlier, the discussion can form many parts. It can be, should I have intravenous fluid treatments or oral fluid treatment? Should I have antibiotics? Should I be readmitted to hospital? Should I have specific ventilation treatment? If I was to develop cancer, is chemotherapy something I really want or don't want? Is dialysis appropriate for me? So there's lots of things we can include in this form. This is interesting because it's differing views. Okay, 80% of patients want doctors to start these conversations with them. But what's interesting is on the flip side, when you look at surveys of doctors, 60% of the doctors you will see feel they can't start these conversations. One, because they may not be experienced. Two, they are scared of complaints or medical legal action in the event they get it wrong. They don't want to start the conversation for fear of upsetting you as a patient. There is time constraints, so they feel that if they start the conversation can go on for a long, long time. They sometimes have a overarching sort of way of approaching things if they're a specialist, and they want to do everything they possibly can for the patient um, within reason. And they find that that's actually quite difficult to then discuss not doing something. So it's a very, very interesting concept that patients want doctors to start, but doctors don't feel they can start. So someone has got to start. So who can start? Well, you can all start. You discuss this with loved ones. You discuss it with the patients themselves, or your loved ones, in terms of, what in these situations, what do you want? Try and make this a normal conversation. I mean, we talk about birth of people as a normal thing. We should talk about death as a normal part of life. We should use opportunities when you're watching TV, watching films, or have had family or friends go through these difficult health changes. These are opportunities to talk about these conditions and how would you want to be treated in this situation. If you're not comfortable talking to your relatives, talk to your GP, talk to the specialist that you're seeing. Really do consider the lasting power of attorney for health and potentially register your views. And then remember, ultimately, if you cannot make a decision and you cannot be in a situation where your decision is taken into account because of various factors, the ultimate decision will be that of the doctor. I'm going to skip this slide, all to say that actually the previous slide alludes to the fact that you can die of two differing things in the sense of death and how we recognize death. One is your heart can stop. Two is your brain can stop, and you may be on a ventilator, which is keeping your other organs going. And there's nuances on that, and that's something for another day. But what is end of life care in this situation when I feel that I can't offer any more treatment, or I recognize someone is dying? Well, the process of end of life is to address the medical, the social, the emotional, and spiritual needs of people. And it's recognizing we're in the situation, it's accepting that we're in a situation, it's understanding what we can manage. So pain, sickness, secretions, nursing issues. Is it possible to go back home? Is it possible to go to a hospice? Is it possible to go to a quiet area in the hospital to manage those end of life hours or days? Knowing what spiritual needs you may want to institute yourself and having that discussion is very important. But we have lots of support within hospitals, and we can arrange for hospital chaplains who can contact our Jane contacts in the community to come and give prayers. We encourage on intensive care for people to pray in the rooms or play music for their loved ones during that last sort of end of life treatment. We obviously encourage family and visitors, but that comes with differing hospitals' policies of having too many people, because the more people you have in intensive care, the more footfall you have, the higher the chances of passing on infections to other people. So sometimes there are limits, but we are usually in an end of life situation very accommodating. Make use of the hospital bereavement services. And after the process of end of life, many people unfortunately aren't necessarily aware, but coroners' processes may then get involved because there is scrutiny on every death that occurs within the community or in the hospital, and the coroners now have oversight of this. And so you may end up in a situation where the pain and the suffering that you've had from a loss is extended because of processes that aren't in your control, but they are due processes to make sure that we have not missed something, or to make sure that we have given the best treatment we can possibly give. Organ donation is very important, and it's something that we always talk about. And today, of all days, is World Organ Donation Day. So please, please, please go onto the website, use the telephone number that is registered at the bottom of the slide, and give the gift of life. You can become an organ donor. No one is going to treat you differently because you're on the organ donation register. The system in the UK has clearly changed as of 20th of May 2020, where the whole situation of organ donation has become an opt-out situation. However, all of these discussions take place, and the views of the family about their loved ones is always taken into account. But the number of people that we can help, which fits in with our Jain philosophy, is evident on this slide. And this is from a few years ago, 2021 to 22, where 4,300 patients' lives were saved because of people being on that organ donation register who were at the end of their life. So I'm going to say thank you very much for listening. Please feedback anything through the chat or directly to Prafula Ben and Nikita Ben. I'll be happy to take questions, comments, or any concerns you have. So thank you again.
Thank you very much, Nikunj Bhai, for an enlightening talk about all the different aspects. Some of the things that I've forgotten about ITU, having worked in ICU for many, many years ago. Thank you for reminding me about that. So we'll carry on with the second part of this discussion, and a lot of things that Nikunj Bhai has talked about may be repeated in the second part of this talk. So let me just share my slides again. So this slide on resuscitation, Nikunj Bhai has covered that in great detail, so I won't go into this. Again, ceiling of treatment is something that Nikunj Bhai shared with us, the respect form. This is from a slightly different form, and it's probably less detailed, but the ceiling of treatment is a discussion that one would take with the consultant or the medical personnel looking after patients. In primary care, in general practice, I tend to have this level of discussion with my patients and their relatives. And over the last week or so, I've had several such discussions because I particularly look after patients who are very frail and elderly. Often what we are faced with in the community is this decision about how far do we go? Do we admit the patient from home to the hospital or not? So this goes a step before the patient actually enters the hospital. So the decision that we need to take in the community is, do you want to get admitted or not? And if you do get admitted to the hospital, all these other decisions will need to be considered. However, a lot of our patients and relatives would ask that if we stay at home, what can you do? If a person is getting dehydrated, can you give intravenous fluids? And many years ago, I used to do subcutaneous fluids in the community, but this is something that is not very commonly done these days. And it's not something that the palliative care teams actually encourage us to do either. The question of intravenous antibiotics also comes along when we say, like, we can give oral antibiotics, but giving intravenous antibiotics is very difficult to manage in the community. So the ceiling of care when a patient remains at home is different from what one would expect in a hospital. Part of today's talk and the focus is, what are the practical things that one needs to prepare for before the day when we have to consider death as something that is inevitable is presented to us. Now, from the religious point of view, from what we talk about all the time and in the classes that we do about learning about Jainism, we are constantly reminded that death is an inevitable part of life and that we need to be ready for that. And in many ways, the whole purpose of our religious practice is to ensure that every moment that we have is counted and every moment is something that helps us further our spiritual goals, and also make sure that the term samadhi maran has meaning to us all the time while we are alive. And when we come to this idea that I want to die very peacefully, then one of the first questions that come to us in the community is, where do you want to die? Would you prefer to die at home? So the term that we use in here is the preferred place of death. And this is something that we record for patients who are approaching uh, that situation. So preferred place of death, home, hospital, hospice. This is something that is worth discussing. When the question arises, there is obviously a lot of fear, and it is an individual battle that needs preparation. But if you never sort of thought about it or asked ourselves what I would do, then sometimes at the end of life it becomes difficult to think about it. And that is why we often have very difficult situations. How do you explore your illness and treatments offered? So, the simple answer that I'm giving is ask questions. Be free in engaging your clinicians in a conversation. Don't hesitate. And in hospital, obviously, nurses, junior doctors, consultants are all very willing. And as Nikunj has explained to us, that in intensive care, these conversations are held very regularly with the relatives, not so much in the ward, but these are things that a lot of GPs would be very happy to sit down with you and discuss what you're going through. And if a relative on behalf of the patient in hospital wants to talk about it, that may be something that a lot of GPs accommodate as well. Apart from the medical personnel, with whom can you discuss these things? It may be your wife, your family, your friends, another clinician, a spiritual guide. And again, this is something that we may want to think about in advance. If I am faced with this situation, who is the person should I be talking to about my situation? Things to get in order, as Nikunj has explained, power of attorney is very important. And we all constantly worry about the things that we've not done, and there's a long list of things to do that we all have. Some of us have huge lists, like me, but things pending that need sorting, and we often leave these to the last moment. And sometimes when death is going to be near, we may have to hurry up. Advanced care planning. There's a term called living will, and this is something that can be done and deposited, and it's something that GPs will accept that this is a decision that a patient has taken. This is something that you can present to the hospital as well. It's also is a document that determines the specific medical care you wish to receive if you are no longer able to make medical decisions for yourself. Doctors and healthcare workers may request this document to understand what treatments to provide during medical emergency or end-of-life care. Unfortunately, in practice, very few people actually make a living will. In my experience of about 30 years, I've had one patient who deposited such a document about maybe about 10, 15 years before the time came. And there were other patients who had expressed their wish to donate their body to medical research, but that was not necessarily a living will about what to do in the event of death. For family members, what is important is to understand what your loved one may have wanted. And sometimes we are left to guess because those conversations have never happened. And then we may remember, are there conversations that they may have alluded to what their wishes would be? How do you manage differences of opinion? And this is something that we often face, that at the end, if there are several relatives involved with this, then people may have very different ways of looking at things. And this is something that I'm sure all clinicians face, whether in primary care, in general practice, or at the hospital, is that some of the relatives may want very aggressive treatment. Some may say that, look, if there is no hope, then maybe we should uh, discuss the ceilings of care and not be very aggressive. It sometimes does become difficult to navigate through very strongly held views. The answer I'm giving here is have a gentle, inclusive approach, and it can be very difficult. Discuss the situation as a family with kindness and consideration of the loved one's welfare. Share the burden of care. So, as the person is approaching the last year of life, there are a lot of care needs for the frail elderly patient, and the burden of care can sometimes fall very heavily on one or two people, and the wider family sharing that burden is very important. And in practice, I've found that suggestions about rotas, about who would do what on what days, actually work very well for some families, but they are a bit difficult to organize, but with a will that can be done. One must remember that there are no perfect solutions. So when one gets frustrated, one has to go back and sit down and try and rework what may not have worked before. Hope is good, but practicality is better. That's what I'm trying to say here, is that it is good to hope that things will things will get better, but one has to often deal with the situation as it arises and find practical solutions. Emotional support, where do you get that from? Well, seek help. If not forthcoming, try again. And we may all have, and I'm talking here from personal experience with my patients, as to how you navigate the difficulties that some families are facing with being so lonely in their caring role for one person. And we must remember that a lot of the carers are themselves elderly and sometimes struggling with the care burden. But what people find difficult is asking others, and you may be surprised what support networks spring up if you try with humility and openness. And the community and our friends and relatives, in my experience, are generous and will do everything that they can to support you. But talking about things frankly is important. Repair rifts. I'm making that particular statement there because those are some of the things that I often see within the community, that there are difficulties that don't even consider the situation, and people sometimes die with regrets, not having repaired uh, their relationships with their relatives and loved ones. Forgive and forget. Remember the virtues of the loved one. Forget the faults. We all have them. And the most important thing I would say for finding emotional support is talk with people and let go of other preconceived ideas and emotional hurts that you might have suffered in the past. After that, traditional routines that we have in our communities help the family members overcome grief very well, and those are important. Practicalities and solving them helps. What happens after all that has finished? Very briefly, I'll talk about grief. So once we've lost a loved one, a lot of us may go through these 5 stages of grief. First of all, there's a shock. One doesn't believe what has happened, and then one gets into a state of denial. And then one gets very angry, and the anger may be directed towards many different people. It may be other family members, it may be directed towards oneself, it may be directed towards health professionals, and that often is part of grieving. Then there is the stage of bargaining, and that is the desire to reverse or change the loss, often through negotiation. And then one gets into a state of depression, which unfortunately may last quite a long time for some people. And there are specialized services which actually help people at this stage. And there are people in our community who actually have a very effective service uh, out in the community. Deep feelings of sadness and regret as the reality of loss sets in. And then we got the stage of acceptance and coming to terms with the loss and finding ways to move forward. Unfortunately, this may sometimes take a few months, years, and I've seen patients who are still grieving for a loved one several years after the event has happened. Some models of grief talk about 7 stages, which include shock and pain as the initial stages. This is something from the NHS website on grieving. These are the things that you should do. Try talk about your feelings to friend, family, etc. If you are struggling to sleep, get sleep tips from Every Mind Matters. What is in green is other uh, websites that connect you to those particular topics. Consider peer support where people use their experience to help each other. Listen to free mental well-being audio guides and try the 6 ways to feel happier. These are the things that we should not do. Do not try to do everything at once. Set smaller targets that you can easily achieve. Do not focus on things that you cannot change. Try and remember that you are not alone. This may not be an issue in our community, but it's something to remember that getting into an addiction of any kind can be very counterproductive and what's mentioned here is alcohol, cigarettes, gambling, and drugs, but some of us in practice have also seen patients getting addicted to sedatives, sleeping pills, and that becomes a problem. And help is available through counseling services in person and online via your GP practice. We all want to die peacefully. Just a reminder of some of the things that we've discussed. And again, this slide that I presented last time, and Rabindranath Tagore in Gitanjali is talking about hope and how actually laying hope to rest is so healing. My desires are many and my cry is pitiful, but ever didst thou save me by hard refusals, and the strong mercy has been wrought into my life through and through. Day by day thou art making me worthy of thy full acceptance by refusing me ever and anon, saving me from the perils of weak, uncertain desire. something for us all to remember. That's the end of my talk. Vulaben, we got enough time, I hope, for questions.
Thank you very much, Ajitbhai, Nikunjbhai. Certainly a really thought-provoking conversation this evening. A lot of the information that you have both shared is, I know, available in some places, but actually to hear it and the way it's been explained this evening, very, very helpful. And these are very important conversations for us to have as families and as communities. I've got a couple of questions. So I thought what we could perhaps try and do is if we take them in rotations, I'll ask one and Nikitaben will ask the other, and we'll try and sort of muddle through these. We haven't got that many here posted on Zoom yet, but I've got two that have been sent to me on WhatsApp. And so I thought, oh, hang on, let's have a look. We got some new ones. Here we go. So I'm going to ask the one that's been sent to me by WhatsApp. And Nikunjbhai, it's a question for you. And then there's some in the Zoom which we'll take as well. So in your slides, Nikunjbhai, you mentioned this differing views, the patient versus the clinician. And both are feeling uncomfortable, I think, to start the conversations. What can we do to kind of make that a little bit more comfortable for both sides?
Yeah, so I think, I mean, it's a very good question. I mean, in terms of what we can do, I mean, so from a healthcare perspective, I certainly try and engage doctors throughout the hospital to encourage them to have conversations with patients, because I think sometimes when you're a doctor and you're so focused on trying to find a diagnosis and give the treatments, you can lose perspective of actually saying, is this the right thing to do? Is this something that we should be doing? So sometimes taking a step back and saying, what is the approach we should take? And doctors really respond well to that, because they understand that obviously we're taught very, very clearly to try and find the diagnosis, to try and give the right treatment, to make sure that we can see the effects of those treatments and the benefits. But they respond well because they sometimes realize that giving treatments can also have effects. People get side effects, people have other illnesses, interactions of things. So they respond when you talk to them about it. And I think sometimes reassuring doctors to say, look, you're trying your best in a situation that is very difficult for the patient and for yourself, and you need to have these conversations because they're important. And you don't need to fear the litigation. There is no litigation. We deal with litigation after. And actually, what we do know from, I'm sure Ajitbhai will support me on this, but what we know from the communication side of things is that if doctors communicate well, the amount of litigation drops. And I think that's very clear. So doctors need to understand that there is support on their half. Patients do also need to take some responsibility, because it's happening to them. You have the right to say, if I don't want something, I can look at all my options presented and I can say, yes, I'll have this treatment, or no, I don't want this treatment. But you've then got to actively say, no, I've thought about this and I have discussed it, or I want to discuss some difficult discussions. And it's sometimes about opening that conversation. It's about saying, I want to discuss what might the future look like. What happens if my condition gets worse? Have you had that conversation with your relatives? Do you feel comfortable? And as Ajitbhai alluded to very clearly in one of his slides, you have so many resources around you supporting you that there's many people you can talk to about different aspects. And you never have to make a decision immediately. That's the other thing. These are conversations. These are things we develop over time. And the more comfortable we become at normalizing this conversation, the easier it becomes to have. And the more honest you can be, the more it's taken in gratitude, because actually people really honor the fact that you've been able to be honest and you've actually come up with maybe not a treatment option, but at least a conversation that will help support the future.
Thank you. And that's really helpful. I think there's a very clear theme this evening, and it's all about actually have the conversation. Let's be comfortable having those conversations, whether that's actually about the care that our loved ones are going to get or not get, as that may be, or whether that's that decision about organ donation that we talked about earlier. So I think conversations and normalizing those conversations, because we often don't like talking about these difficult subjects, and death is one of those that we don't want to talk about. But you know, it is very, very important. And Ajitbhai, you summed up something quite well in one of your slides, which is about that question of the care of the loved one, and making those decisions with the respect to that loved one person that is actually going through this process of life, and then the cycle of not life, because it's all part of the same conversation. Life and death, it's a cycle. So if we do want to kind of make this a lot easier on ourselves, I think the one big message here is conversation, and being comfortable having those conversations. There is one other question which has just come up, and I'm going to ask that after Nikita Ben's question, which I think is one from Zoom. So Nikita Ben, do you want to take that one?
Yeah, sure. We've got a question from Punit Bhai. He's asking what respite options are available and how to access them. And this is specifically for a weekend to a couple of weeks.
Okay. Can I take that?
Yeah.
So, Punit Bhai, this is something that should be available very easily, used to be available very easily, but these days does require negotiations with the social services. And a lot of care homes, depending on the level of dependency that your loved one has and the degree of frailty, a lot of care homes offer respite care, and that can be for a weekend or a couple of weeks. It is something that local authorities will actually sanction. However, if the financial situation is such that the person does not qualify for free respite care, they may ask the family to contribute or the person themselves to contribute, but respite care is available. And in the care homes that I've worked with, there are often patients who come for respite care, usually for a couple of weeks, because that gives the carers a holiday, and it's something that can be discussed. And if you have a particular situation in mind and you're struggling with that, then feel free to call me privately, and I can guide you through that.
Thank you very much, Ajitbhai, for that. The question I've got is, and this is a person's experience. So we often in our community have quite large family units, people, multiple siblings, perhaps taking care of an elderly mom or dad. If they're in hospital, how do we communicate so that actually the communication channel is very clear to the medics and the people taking care of the elder person? Is it that multiple conversations happen with multiple members of the family? Is that helpful, or is that not helpful? I'm going to go to Nikunj because I think this probably happens a lot in an ICU setting.
Yeah, no, you're absolutely right. This is a very, very frequent occurrence, and there's different ways to handle this. So I think some of it depends on the family. So one of the things we always do in intensive care is we get to know the family, because if there's a family unit that work very well together and they are all on the same page in terms of the conversations and what needs to happen next, it's very easy to update everyone together because everyone is hearing the same message, but we also interpret that as they understand the same message and can disseminate the same message away from the intensive care. When there's very large families with multiple views and different conversations and differing views, one of the strategies that we sometimes employ is we say, actually, what we'd like you to do is identify 2 or 3 people, because there will always be 2 or 3 people within most families that people respect or the majority respect in different ways. And therefore, 3 people coming in together as a family unit, having those conversations and being able to disseminate that conversation to others is very useful, because the other thing that happens is it strengthens the bond between those 3 people, but it also allows them to communicate better, which means everyone is actually actively talking. The more people you have and the more ideas you have, sometimes, yes, does muddy the waters a little. So it's one of the strategies that you can employ. And I've been in situations where families have actually said, we would much rather have X, Y, or Z. And usually it comes because someone has got someone who works in healthcare and someone who knows someone who works in healthcare, and they say, can we involve them in the conversation? And as long as the patient has agreed, if they can, or the next of kin in an intensive care situation, the next of kin has agreed that they can be involved and be the link person for the disseminating the information, it's much better to have those conversations. The other thing I would say is remembering our NHS is resource sort of poor at the moment. We don't have the amount of staff available. So if we're having discussions with multiple people on multiple occasions, then we are not giving that amount of time to the patients. So that can also be a sort of an issue where lots of different people want everyone's time. So having clear processes in place is very important, and that can be initiated again from the hospital or from a loved one's family.
Thank you, Nikunj. Thank you for that. And I imagine that's actually quite challenging for both parties to manage. So the more easier and comfortable that we can all make, it is better for the patient, I guess. In the end. Nikita Ben, I think you've got a question.
I think Ajitbhai has responded to that. It is, do we notify our GP regarding our LPA?
Yeah, basically I've said that it's always useful for the GP practice to know that there is an LPA in place, and they may not necessarily ask for it, but it always helps to know who to have a conversation with in case there is a situation where the patient themselves cannot actually take a decision. A lot of our elderly patients do have LPAs, or at least they alluded to that there is an LPA and this is the person. Some patients actually give us copies of the LPA, so we know the details of who holds the LPA for that patient. And the GPs don't need to have sight of the LPA for financial purposes. It's just the health and welfare.
Thank you very much, Ajitbhai. Right, we don't have any more questions, but I just wanted to sum up a couple of points, if I may, this evening. So thank you everyone who has joined us. At one point we had 94 devices, I think. So devices means obviously a device, but we have multiple people maybe on those devices. This session has been recorded, as was the first one. So they can be found on the Oshwal YouTube channel for anyone that wants the information and actually the slides. I thought the slides are actually very, very useful just to navigate some of the processes and language that we may face in hospitals, or particularly in an ICU situation. So if anyone wants to look at those recordings, they'll be on the Oshwal YouTube channel. This evening, as I was saying earlier, of course, we've got Ajitbhai here, a very well-known face here in the Northwest area, and then we've got Nikunj, very well-known face over in the South area. And I've got a message on Zoom saying, thank you for an insightful session into a very delicate matter. And indeed it is. These are very difficult conversations for everyone to navigate. And that's why we're having some of these sessions to try and kind of make it a little bit more easier for all of us to start thinking about this. But in summary, I guess the 4 things that I wanted everyone to kind of take away from part 1 and part 2 is advanced care planning. We talked about that in part 1, and we went into a lot of detail into that. The living will, which Ajitbhai was quite surprised you saying only one person in your 30-year careers has done this. I've actually, I guess I'm maybe unusual in that I know about 10 people who've made living wills, more recently. The LPA.
And more now, but
Yeah,
I think
exactly.
I'm talking about when I was in full-time practice. Yeah.
Yeah, and I think that the living will is very important, and sometimes I do see people confusing that with LPAs or confusing that with their actual will. But the living will is actually your wishes about dealing with matters that are personal to you, so that you've left some clarity for the people who may then need to deal with the situation. So it's very important that we make those wishes known. LPA, as you said, both the healthcare one and the financial one, and very important that the LPA is made so that your wishes can be, translated, respected by your nominated person, that you have your nominee. And again, LPA gets confused with the will. So the will is after you've died, it will be read when you're comfortable elsewhere. But the LPA is actually something that makes you comfortable now and deals with the matters that are very important to you as your healthcare and your, the decisions that get taken about your care, but also your financial world. And then the final one for me, and I think we have all said this, is this discussion point. So starting the conversations and making sure that we have the conversations, but, and this is where I come in with a little bit of a health warning. Google is fantastic, but, just kind of use it with a little bit of, care, because it doesn't give you all the answers and it is subjective. So often we go to a professional with answers from Google, and that's not going to help us build bridges in a situation where everyone is stressed, everyone is trying to navigate a difficult situation. So good to, I think, just have a heart-to-heart, honest, open conversation. As Nikunj said, that will help to put both parties at ease. And remember, they've never met you before as well. You're in a medical facility where they've not met you, you've not met them. So it's almost like building those relationships and building those bridges. I think the most important point also is this point of language. We're very quick to kind of often not understanding the full context of the language, often the jargon, and worse for our elders because maybe they don't even understand the English bits of this. So if we are in doubt and we don't understand, then ask for a translator. Do ask for that translation, ask for the translator. And Ajitbhai, you made a very good point, which was about, bereavement care at the end, the grief, that 5-stage grief process. There's nothing wrong with asking for that support. If we feel that we don't have that support in our community networks or our family networks or our employment networks, then ask for that support elsewhere. There are lots of organizations offering this kind of support as well. And of course, that subject very close to my heart, which I'm going to talk about again today on World Organ Donation Day. So Nikunj, thank you for that heads up. The figures in your slide, though, are, as you said, from 2022, July 2025 this year, the figures are much worse. So we now have 8,000 people on the waiting list for a transplant. It's the worst it's ever been, and more work for all of us to do. So what remains for me to say is thank you to everyone, all of you for joining us. Thank you, Nikunj Bhai, to join us after a shift that you've done, no doubt, in ICU. Ajitbhai, thank you very much. I know it's been a crazy week for you as well. I know you were on Zoom yesterday as well, and you're here today. So thank you. Nikita Ben, brilliant. Thank you very much. And behind the scenes, I'll say a huge thank you to Ketan Bhai, who's been taking care of all of us from a tech perspective and making sure that we're all sticking to our timings. So, as I said before, to recap, this is being recorded and it will be on YouTube. We've got lots of messages on Zoom, people thanking us for a very, very brilliant talk. There you go, lots of thank yous. So thank you, everyone, and Jai Jinendra, please take care.
Jinendra.
हरिहंत प्रभु ना दर्शन करता ओम नमो हरिहंताणम सिद्ध प्रभु ना दर्शन करता ओम नमो सिद्धाणम आचार्यों ने वंदन करता ओम नमो आयर्याणम उपाध्याय ने वंदन करता ओम नमो उपाध्यायाणम सर्व साधु ने वंदन करता नमो लोए सब साहुणम सम्यक दर्शन मुझने मर्जो पंचन मुक्तारो सम्यक ज्ञान मुझने मर्जो